the gastrointestinal and urinary system.
What are you waiting for?
Let's go!
So for abdomen, we want to perform first history taking. We want to obtain health history related to GI problems like appetite, especially for patients with anorexia, weight loss, heartburn, excessive gas or flatus, regurgitation, vomiting. So we want to take note the amount, type of vomit, color. We want to also check for abdominal pain and its characteristics, medical problems related to abdomen like hepatitis, gallbladder problems or pancreatitis, surgeries of the abdomen, use of tobacco, alcohol, and illegal drugs, hereditary disorders affecting the abdomen, bowel movements, and urination. For history taking about bowel movements and urination, we want to note frequency, consistency, pain, color, difficulty. Now for history taking about urine, we want to check for color changes, voiding pattern changes, hesitancy, frequency, urgency, nocturia, and incontinence. And then we want to prepare the required equipment and then explain the procedure to our patient. We want to also prepare the patient by putting a flat pillow which may be placed under the client's head for comfort. We want to slightly flex the client's leg by placing a pillow or rolled blanket under the client's knees to help relax the abdominal muscles. We want to also drape the client with sheets so that the abdomen is visible from the lower cage to the pubic area. We want to also instruct the client to breathe through the mouth and take slow, deep breaths, which promotes relaxation. And before touching the abdomen, we want to ask the client about painful or tender areas and always assess these areas at the end of the examination. We want to also watch the patient's face for signs of discomfort during the examination. For abdominal examination, we start with inspection. We want to observe the coloration of the skin. We want to note the vascularity of the abdominal skin, note any striae or stretch marks, assess for lesions and rashes, inspect the umbilicus, note color, location, and contour. We want to inspect the abdominal contour. This is done sitting at the client's side. We want to look across the abdomen at a level slightly higher than the client's abdomen. We want to also observe the aortic pulsation and observe for peristaltic waves. For auscultation, we want to auscultate for vowel sounds. We want to use the diaphragm of the stethoscope and make sure that it's warm before you place it on the client's abdomen. We want to also apply light pressure or simply rest the stethoscope on a tender abdomen, beginning in the right lower quadrant and proceed clockwise covering all quadrants. We want to listen for at least 5 minutes before determining that no vowel sounds are present and that the vowels are silent. We want to confirm vowel sounds in each quadrant and listen up to 5 minutes with a minimum of 1 minute per quadrant to confirm the absence of vowel sounds. So vowel sounds normally occur every 5 to 15 seconds, so we want to note the intensity, pitch, and frequency of the sounds. We want to also auscultate for vascular sounds, so we want to use the bed of the stethoscope to listen for bruits or low-pitched murmur-like sounds over the abdominal aorta and renal, iliac, and femoral arteries. We want to also listen for venous hum. Using the bell of the stethoscope, we want to listen for a venous hum in the epigastric and umbilical areas. For percussion, first we want to percuss the abdomen for toads. We want to lightly and systematically percuss all quadrants. We want to do the abdominal percussion in sequences, which should proceed clockwise or up and down over the abdomen. Second, we want to percuss the span of the liver by determining its lower and upper borders. To assess the lower border, we want to begin in the right lower quadrant at the midclavicular line and percuss upward. We want to note the change from tympany to dullness and mark this point, which is the lower border of liver dullness. To assess the upper border, we want to percuss over the upper right chest at the midclavicular line and percuss downward, noting the change from lung resonance to liver dullness. We want to also mark this point because it is the point of the upper border of the liver dullness. We want to measure then the distance between the two marks, which is the span of the liver. Third, we want to percuss the spleen. We begin posterior to the left mid-axillary line and percuss downward, noting the change from lung resonance to splenic dullness. Fourth, we want to perform blunt percussion on the kidneys. We want to place our left hand against the costovertebral angle over the 12th rib and use the ulnar side of your right fist to strike your left hand. Fifth is bladder percussion. We want to ask the client to empty the bladder first, place the patient in a supine position, and start at the symphysis pubis and percuss upward toward the bladder and over it. For palpation, first we want to perform light palpation. So light palpation is used to identify areas of tenderness and muscular resistance. Using the fingertips, we want to begin palpation in a non-tender quadrant and compress to a depth of 1 centimeter in a dipping motion. Then gently lift the fingers and move to the next area. For deep palpation, we want to deeply palpate all quadrants to delineate abdominal organs and detect subtle masses. So using the palmar surface of the fingers, we want to compress to a maximum depth of 5 to 6 centimeters and perform bimanual palpation if you encounter resistance or to assess deeper structures. We want to also palpate for masses, note their location, size in centimeters, pulsatility, shape, consistency, and demarcation. We want to also note tenderness and mobility. So we do not want to confuse a mass with an organ or structure. We want to palpate the umbilicus and surrounding area for swelling, bulges, or masses. Then we want to palpate the aorta. We want to use our thumb and first finger in the epigastrium and slightly to the left of midline. We want to assess the pulsation of the abdominal aorta. Then we want to palpate the liver. So we want to note consistency and tenderness. To palpate bimanually, we want to stand at the client's right side and place our left hand under the client's back at the level of the 11th to 12th rib. We want to lay our right hand parallel to the right costal margin. And then we want to ask the client to inhale, then compress upward and inward with your fingers. And then we want to palpate the kidneys. To palpate the right kidney, we want to support the right posterior flank with your left hand and place your right hand in the right upper quadrant just below the costal margin at the MCL. To capture the kidney, we want to ask the client to inhale, then compress your fingers deeply during deep inspiration. We want to ask the client to exhale and hold the breath briefly and then gradually release the pressure on your right hand. Now, if you have captured the kidney, you will feel it slip beneath your fingers, and to palpate the left kidney, we want to reverse the procedure. To palpate the urinary bladder, we want to begin at the symphysis pubis and move upward and outward to estimate bladder borders. Then we want to test for ascites. First, we want to test for shifting dullness. If you suspect that the client has ascites because of a distended abdomen or a bulging flank, we want to perform this special percussion technique. First, the client should remain supine, then percuss the flanks from the bed upward towards the umbilicus. We want to then note the change from dullness to tympany and mark this point. Now we want to help the client turn onto the side and percuss the abdomen from the bed upward and mark the level where dullness changes to tympany. Then we want to perform the fluid wave test. So the client should remain supine and you will need assistance with this test. We want to ask the client or an assistant to place the ulnar side of the hand and the lateral side of the forearm firmly along the midline of the abdomen. We want to firmly place the palmar surface of your fingers and hand against one side of the client's abdomen and use your other hand to tap the opposite side of the abdominal wall. For test for appendicitis, we want to assess for rebound tenderness. So if the client has abdominal pain or tenderness, we want to test for rebound tenderness by palpating deeply at 90 degrees into the abdomen away from the painful or tender area. Then we want to suddenly release the pressure.
We want to assess for PSOAS sign. We want to ask the client to lie on the left side, hyperextend the right leg of the client. For assessing for obturator sign, we want to support the client's right knee and ankle, flex the hip and knee and rotate the leg internally and externally. For test for cholecystitis, we want to assess for right upper quadrant pain, or tenderness, which may signal cholecystitis or inflammation of the gallbladder. We want to press our fingertips under the liver border at the right costal margin and ask client to inhale deeply.